The title of today's talk is How Much Health Can a Ton of Carbon Buy? The question mark there is doing a lot of work, because I hope to engage you in this. This is an exploratory study. It's really, I'm trying to ask which questions are appropriate. Is this even a valid question? And I hope with your backgrounds and interests, you'll have a few things to say at the end of this talk. So I am going to say it's really up to you. If someone has any pressing points and they would like to clarify, if we were in a room, I would probably catch your eye and ask you to ask a question. So if the moderators are happy to monitor the chat, if there's anything that comes up and people want a clarification as I go, please interrupt. So a little bit about me first. So I'm from the UK, from Edinburgh in Scotland, where I grew up. And I went to medical school in the north of Scotland, a little university town called St Andrews, most famous for its golf courses. And then I went to Manchester. I had a brief period at ISE, which is the centre of John Harris, philosopher John Harris, where I was based with Sarah Chan, another philosopher there. And it really stirred in me an interest in philosophy. But I'm quite a practically orientated person. So I decided to do a master's in philosophy, politics and economics of health at University College London. And I really found that so fascinating, realizing that actually health policy, drawing on my background, of course, in medical school and medical studies, with public health and interests in other areas, it actually does come together. There is a field where you can bring these ideas together. So I briefly, I would say I'm very influenced by the ideas of Iris Young, who we can talk about later if anyone's interested. And then I had some practical experience, both working in a hospital for 2 years and then working in Public Health England with this man, Professor Paul Cosford. He's the medical director, the sort of Camilla Stoltenberg of the UK. And then, in fact, I did go and briefly work in Camilla Stoltenberg's institute for a few months when I moved to Norway about 2 years ago. So I started my PhD here at the University of Bergen a year and a half ago, working with Professor Ulla Norheim. And of course, I therefore have become more and more influenced by priorities and priority setting. And although my work is primarily in Ethiopia, or at least it was planned to be before the pandemic, the nature of the pandemic has changed so much for so much of us. It's difficult to travel to Ethiopia. It's difficult to plan. So I've really been delving into other ideas, and this is one I'm going to talk about today. So I've got 4 starting premises, which I'm just going to run past you and talk about briefly before I move on. Firstly, averting climate change is important. Secondly, temperature rises are essentially directly proportional to greenhouse gas emissions. Thirdly, that carbon is a limited and finite resource. And fourthly, following from this, that the carbon budget must be optimized. Now, I'll explain these in a little bit more depth. So why climate change? I think I'm not going to delve into this question, basically. I think it's a valid discourse in legal discourse, philosophical discourse, public discourse, political discourse, to say that climate change is a valid goal, addressing climate change. So I'm not going to dwell on that. Secondly, the idea that temperature is cumulative to carbon emissions. So this, just to clarify, this may be familiar to all of you, but this is from the International Panel on Climate Change report, most recent report. And essentially what this shows is the upward aiming arrow, shows you that as cumulative carbon emissions, so that's all carbon emissions in the past, go up, you essentially get a direct rise in temperature. The arrow that's going down takes a slightly more arched trajectory. And what this tells you is that it's slightly slower to cool down temperatures as compared to the speed which temperatures increase. So basically this would tell us that actually it's better to reduce carbon emissions than aim to pull them out of the atmosphere later. That's more of a side point. Of course, this doesn't tell us about tipping points, which many of you will have heard of. So these are both the known unknowns and the unknown unknowns. Thirdly, that carbon is a finite resource. Now, this is a slightly daunting table, but don't be daunted by it, okay? So look at the orange boxes. So we often talk about 1.5 degrees of temperature rise and 2 degrees of temperature rise. Now, all I want to just highlight here is we know with a pretty high level of certainty how global temperatures will be affected by a certain amount of carbon dioxide equivalents in the atmosphere. And what this graph is, what this table is showing you is roughly around 1.5 degrees of rise. We know that this is the budget. Now, the metric doesn't matter, but it's gigatons. And we can see with certain levels of uncertainty how sure we are. 2 degrees, we can also see that the carbon budget is a bit higher. Now, the reason why carbon budgets are really, really important can be demonstrated with this graph. Again, don't be daunted by it. This essentially shows many different lines with the same area under the graph. And because we're talking about budgets, we're not talking about annual emissions, we're not talking about percentage decreases, we're just talking about an absolute number. And what this shows is that the area under the graph has got to be the same. Now, whether you start early, you start in 2000, you had quite a shallow graph, like a shallow decrease. Whereas the later you start, the steeper the increase. Now, it's a bit small perhaps, but hopefully you can see that what this graph is trying to show at the top now is that if we start decreasing emissions from around 2017, we could decrease them around 3% per year to 2100. And that would be consistent with 1.5 degrees of warming. But if you wait until 2025, which is sort of where we're heading, you've got to start reducing by 15% per year. This is where it gets into extremely daunting territory, and really is something like this has never been achieved before. So this is just something about budgets, the idea that the budget is finite and we've got a limited budget. So how do we use that? So therefore it follows to ask, how do we optimize the budget? Now, thankfully, we've got extremely good resources to draw on here. Firstly, the IPCC 1.5 degree report, which talks in great depth about carbon budgets and trying to understand these. And it also shows in great depth the differences on impacts between 1.5 degrees of warming and 2 degrees of warming. And they are huge. So this, the differences, and I should say actually, all the links are in the presentation and I'm happy to share it afterwards. So I don't intend you to read all the detail, just know it's there and you can look at it afterwards. So the main difference between 1.5 degrees and 2 degrees are that there is a big difference. About double the number of people will be exposed to major water stress. Ecosystems will be extremely affected in 2 degrees compared to 1 degree. Similarly, about double the number of people will be exposed to coastal flooding. Food systems and poor agricultural yields will be increased about 10 times in 2 degrees of warming versus 1.5 degrees of warming. And with health, there's a huge number of higher risks that come at 2 degrees of warming that we don't see at 1.5. So this is to show not only is there a difference between carbon budgets, but carbon budgets allow us to see that if we choose to do this, how do we do it in the optimal way? Well, you've got to know something about the risks and the benefits of getting there. Finally, a key question that will come up is, well, where are these emissions actually coming from? And who determines what an optimal pathway looks like? So again, you may be quite familiar with this, but this graph is from the International Energy Agency, Africa Outlook, and it's showing in gray here is cumulative emissions over the 20th century, mainly. And then in stated policies, how much emissions do we expect over the next 20 years? And broadly, you can see this is the United States, China, European Union, and you come down to the lower income countries, particularly Africa, and the planned emissions are extremely small, as well as the historical ones. So this is really a question of a balance on whose terms. What does an optimal pathway actually look like, and in whose interest is it? So I'm just going to fast forward now and just really focus from now on health impacts of climate change, but we can return to all of that later if you would like. So I think there's been three phases of my reading of the health and climate change field. So firstly, you had the main focus was on the health impacts of climate change. So that was launched into the limelight really with the 2009 Lancet Commission on Health and Climate Change, which described climate change as being the biggest global threat of the 21st century. You then had the International Panel on Climate Change Human Health Report, came in 2014, and the World Health Organization did their own quantitative risk assessment of climate change in 2015. So this was a real focus on what are the health impacts of climate change. The second was more of an integration of health and climate change. So this was captured by the Lancet Commission, the second Lancet Commission, which said tackling climate change could be the greatest global health opportunity of the 21st century. So not so much about impacts, but what are the potential opportunities of addressing climate change? So the idea of possibility. A huge numbers of reports have been written around this topic of how do you promote equity whilst tackling climate change within the health sector. Again, all the links are in the presentation. Now, and I should say there have been various moves in this direction in Norway too. The final phase, which we're moving into now, which is more focused on the climate impacts of healthcare. So what is the volume of greenhouse gas emissions that occur from the health sector? So over the last 2-3 years, we've had reports from an organization called Healthcare Without Harm, which has tried to assess healthcare's climate footprint, global climate footprint. We've had more detailed studies of international comparison of healthcare footprints of healthcare systems across the world. And then there's increased sort of interest from both academic journals, from advocacy organizations and research groups too. And as well as that, it's more detailed rather than going purely on the system level, but increasingly going into the detail of, well, how much greenhouse gas emissions do you actually have from an operation or a single operating theatre over the course of a year? So we'll come back to whether these are the right sort of formulation of questions later. So following with that is, well, we now know that the healthcare sector probably contributes around 4 to 5% of global greenhouse gas emissions. So how much is 4 to 5%? Well, I'll come to that in a moment. Just briefly to say, these attempts to quantify the health impacts of healthcare, it's a bit of a convoluted twist, but if you imagine that 4 to 5% of emissions come from healthcare, and we know that emissions will cause harm, the question is how much harm comes from healthcare? And there has been attempts from that. So this is Eckelman in the United States has looked at this in detail for the American and Canadian healthcare system. Philosophers John Nault and John Broom have also looked at this from a slightly different perspective. So how much harm actually comes from an average person's emissions. It's quite helpful. And then of course, it's thinking about integrated assessment models. So this really influences policy and what mortality function do you use in these models? Again, what you put in determines what you get out. So the question I was going to come to was how much is 4 to 5%? 4 to 5% of global greenhouse gas emissions. Now this graph shows greenhouse gas emissions by sector. It's a bit complex, but 4 to 5% is more than the total of aviation and of shipping combined. So it sounds perhaps to the untrained ear, 4 to 5% might sound relatively small, but actually it's quite big, given that we need every sector and every part of society to essentially come to zero carbon emissions as soon as possible. Delving into the detail of this, let's call it 5%. Where does that come from? And again, you can see countries like United States are quite dominant, about a quarter of that. China is also quite substantial. But then you have countries like India, over 1 billion people, contributing only 2%. And all other nations, which includes a huge number of nations, including all the Middle East, Gulf states, North Africa, well, Sub-Saharan Africa to South America, that comprises about a quarter, 25%. So there's a huge discrepancy between regions of the world and between countries. And for those that are familiar with scope 1, 2, and 3 emissions, I won't delve into it now, but most of these emissions are scope 3 emissions. So they occur upstream and often are not accounted for in a country's national carbon accounting. So now let's return to the question at hand. How much health can a ton of carbon buy? I hope that was useful in bringing up to speed people who are less familiar with this literature. But if you have any questions and any clarifications that are needed, please just ask. So I take my inspiration for this paper from the DCP, Disease Control Priorities in Developing Countries report from 2006, in which it was a highly influential document, which was really guided towards policymakers and specifically ministers of finance to provide incentives to improve health, showing that good health actually contributes to economic growth. But another thing that I found extremely interesting was in the preface is a table entitled "How Much Health Will $1 Million Buy?" Again, I don't think it's important that you look at the details, so I've kept it quite small, but you can look at it later. And essentially what they did was listed a number of interventions. They then found out the costs per disability adjusted life year, and then they multiplied that up to find how many disability adjusted life years could you avert for $1 million. So how much health could $1 million buy? I thought it's quite interesting and wondered, could we use that concept for carbon? Now, there's still great hope that this economics-based approach to reducing global health inequality could succeed. So this is Dean Jameson writing 15 years on from this DCP1, the world converging within a generation. Now, I mean, the pandemic has obviously put that to the test, but so too is climate change. It presents a new threat. And I think it's relevant to wonder, what is the relationship between health and carbon? So let me just run you through a few of my thoughts, and hopefully this is useful to getting my perspective on how you would answer this question. I think the first key data point is climate projections. So I felt I wanted to verify the robustness of the carbon budgets. I wanted to be clear about current temperature projections and uncertainties, and that includes catastrophic risks, the anticipated health impacts at different temperatures, and as well as that, the range of adaptation and mitigation pathways that are actually available to us. And in this regard, I think all of that can be found in the International Panel on Climate Change. I think it can be found in their work. And they have a 6th assessment report coming out next year with a series of briefing reports over the next few months. So I was fairly kind of comfortable with that. Secondly was on healthcare emissions. I felt like I wanted to know what is the total carbon emissions and healthcare emissions by country, per capita, and by income level, so that I could think about not just absolute emissions, but equity and other dimensions. I would also want to know a breakdown of these emissions. Where are they occurring? You know, what part of the healthcare system? Are they something we can do something about, or are they not? So mitigation potential by source of emissions. Now, in this regard, inventories and action plans are quite useful. So this is from Norway, from SSB, and we are already pretty good at doing carbon accounting in Norway, like in many countries. And we have quite strong ambitions, such as put out in the Klimaplan earlier this year. In health, it's a slightly earlier stage, but there are definitely action plans that have emerged. So this NHS Wales Strategic Delivery Plan was released earlier this week. And the NHS England delivering a net zero healthcare service was released a few months ago. So these put out some action plans. They give some clear ideas about where do emissions come from, what can we do to reduce them, and how do we think about trade-offs and priorities. So it's a slightly an earlier stage than broader carbon inventories across the rest of society, but it's developing. So I'm fairly sure that we've got something to work with there. The third is health outcomes. You know, and this is the key, arguably. What is the relationship between carbon emissions and health outcomes? And following from that, what is an optimal emissions pathway? And I was thinking actually of relevance to your center. This is, I presume, a question that would come up. You know, it's not that anyone denies that climate change is important or that we should do something about it, but why should we do something in this place now, in our healthcare facility, try and reduce our emissions? And I think this is quite useful to think, well, we should know what the relationship is between carbon emissions and health outcomes. So there's been a lot of work on this, but one thing I'll just say is that the Institute for Health Metrics and Evaluation, which does a lot of the global burden of disease work, they've recently, over the last year, I think, introduced non-optimal temperatures as being an independent risk factor into their calculations. So they're extremely, reliable group, and it's interesting to look at how they've decided to approach climate change. The Lancet Countdown, which is an independent academic consortia, which has been working to better understand the relationship between health and climate change. They've taken a slightly different approach to date, but this is just from the 2019 report. And this shows per capita greenhouse gas emissions on the y-axis and per capita GDP on the x-axis. And broadly what you can see is there is a fairly sharp rise, and then a sort of a leveling off. I mean, America is an outlier, as it's normally an outlier, so you can maybe take that with a pinch of salt. But there is a leveling off, so it makes you wonder, well, how dependent are we on carbon emissions to deliver good healthcare and to provide health for people? So I try to think about this in three perspectives, which I'll introduce to you now: global, health service, and clinical level. And hopefully this will be resonate with some of the work you're doing. So I would say the first I've called the globally just perspective. So again, slightly daunting graph perhaps, but it's actually quite simple. Listed as a number of countries from around the world with their healthcare emissions per capita in red. And what I've done is, don't worry too much about the units and the axes. It's just meant to be illustrative. And then what you can see is in gray here is the carbon emissions intensity of the health service. Emissions intensity is the kilograms of CO2 that you produce per unit dollar spent. And broadly what you find is that emissions intensity is very low in high income countries. So Norway has a very low emissions intensity. But as you go from the countries which have the highest per capita healthcare emissions, they generally have pretty low carbon emissions intensity. Now, as you go to the other end of this graph, India, Kenya, China, Chile even, they generally have much lower healthcare emissions per capita, but the emissions intensity is in fact higher. So it's a bit of a double burden actually, because emissions intensity is normally something that's out with the healthcare system. It's not really something you can do that much about within the healthcare system directly. So that's one dimension of this graph. The other dimension is to just show you that if you map healthcare emissions per capita with a metric of called the Healthcare Access and Quality Index, which a metric of avoidable mortality, what you broadly find is that where 100 is good and 0 is bad, what you generally find is that actually the countries which are polluting the most carbon have the least avoidable mortality, and the countries which are polluting the least have the highest avoidable mortality. Now that might be obvious, but I think in some ways what we've got to question is the idea that does any country or any person have a right to emit any more carbon than anyone else? I mean, my own perspective on this is no. So therefore, even if this seems quite obvious, it's not necessarily right and does need to be interrogated. So the second perspective is to think about the health service perspective. So again, remember that the aim of this paper is to ask how much health can a ton of carbon buy? So one way of thinking about it is think about interventions. So this is just one for cataract surgery, and it just taken from the paper. So cataract surgery, you can look at, well, how much carbon does it use to perform that surgery? So in high income countries, it's about 0.18 tons. Again, doesn't really matter, but you can see that in low and middle income countries, it's generally much lower. This is from India, about 0.06, 0.006 even. The DALYs averted, so that health gains that you get are pretty similar. So then you can look at, convert that into how much carbon do you have to use to avert one DALY, one disability adjusted life year. And you, of course, then get a difference between high income countries and low income countries. And then you can just, the inverse of that is to say how many DALYs are averted per ton of CO2. So again, so this is a sort of equivalent of how much health can $1 million buy, how much health can a ton of carbon buy. And in a way it's abstract, but in another way, it's actually trying to show how much health gains can you get from carbon emissions in healthcare. And often we don't really ask that question directly. And then if you compare high income countries and low income countries, again, there are differences in the gains you get. Normally we just reconcile that with the fact that costs are higher in high income countries, financial costs, and there's sort of degree of acceptance of that. In high income countries like Norway, we choose how to spend our money, and we choose to spend quite a lot of it on healthcare. And I suppose I want to introduce this critique or question of, well, actually, when it comes to emitting tons of CO2 into the atmosphere, it's not clear to me that a country like Norway has any more right to pollute than another country in low and middle income countries. The final perspective that you could take on this question, or I've taken on it, is the clinical perspective. So this is thinking about marginal benefits. So this is a graph, again, don't worry too much about the actual emissions, it's meant to just be illustrative. So this is looking at hysterectomy, the cost and carbon emissions by mode of intervention. So what you can see is this is conventional, either abdominal or vaginal hysterectomy. And what this shows is that carbon emissions are relatively low. The cost is relatively low. Laparoscopics, that's keyhole, the carbon emissions are relatively higher, and the financial costs are relatively higher. And then robot-assisted laparoscopy, that's highest, so highest in cost and highest in carbon emissions. Now, the key for those who aren't clinically minded, it might be intuitive already, but there is a shift towards robotic assisted laparoscopic surgery, largely in the name of improving patient safety and quality and outcomes. Now, I suppose the question is then, if you know that carbon emissions lead to some harm, and we're increasing emissions, but having improving health for our own patients, who pays for the cost of that overseas? Now, this perspective, this clinically orientated perspective, maybe impacts on the margins, has been getting more traction of late, at least over the last year or so. So this is a systematic review of the carbon footprint of different surgical operations, published by a group in Brighton, I believe. This is a study looking at the carbon emissions from personal protective equipment, PPE, used in the first 6 months of the pandemic in England. And here's another report from a couple of years ago, entitled Beyond Financial Efficiency, trying to incorporate environmental sustainability into economic evaluations. And they used it to assess renal medicine or kidney dialysis. So there is a sort of shift in trying to think about these sorts of questions. Now, I've given you a real, as I said I would at the beginning, I've tried to discuss questions. I haven't come here giving you tons of answers, and also bearing in mind that we may come from different disciplines and backgrounds, so I haven't wanted to delve too much into the technical details. Happy to in questions. I think there's 4 main outstanding questions from this work. Firstly, as I've alluded to, distribution of resources. What actually is a fair distribution of carbon emissions for health? Secondly, carbon footprint calculations. Should health and healthcare be part, or a bigger or a smaller part, of societal efforts to decarbonize, to reduce carbon emissions? Should we be doing more in the healthcare system because we work in health? Or should we be doing less because actually healthcare is really important and we get so many benefits from it? Thirdly, life cycle analyses. I haven't delved into these, but essentially that's the method that's being used to calculate the carbon emissions from different interventions and different materials that we use in healthcare. These are relatively time and labor intensive to produce, but it has been used quite widely in other sectors of society. Now, collecting data and regularly updating it, well, that has costs. And there are trade-offs, opportunity costs of spending money and resources on time collecting this data. So what are the costs and benefits of more data? Is it a data problem or is it not? And finally, this is a question I'm particularly interested in, is about responsibility. And I said at the beginning that I was interested in the philosopher Iris Young, and her work is a lot on responsibility and thinking about how do we determine who should do what? And the question I've been wondering about is, are healthcare carbon emissions special? Is there anything that distinguishes them from other carbon emissions from other areas of society? If so, what is it? And I wonder if that's something that I suspect intuitively many healthcare workers actually feel healthcare carbon emissions are special. But I'd be interested to know your thoughts on that too. So thank you so much for listening. This is my email here, and I look forward to your questions.